thank you once again, everyone, for joining our Novo Nordisk Network for Healthy Populations monthly seminar series. Today, we're really excited to have Doctors Iliana, Lega, and Lisa McCarthy to present for us. Before we get started, I would like to acknowledge the land on which the region of Peel and the University of Toronto Mississauga campus operates, which is part of the treaty lands and territories of the Mississaugas of the Credit. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit, and today this meeting place is still home to many Indigenous people from across Turtle Island, and we are very thankful to have the opportunity to work on this land. I am coming to you from Treaty 13 in Toronto, and I'm also personally grateful to this land that has provided me with a place to live, work, and raise my family. I do recognize that this privilege comes from stewardship and care of the Indigenous peoples who have lived here for millennia. So welcome everyone once again. Thank you for attending today's seminar entitled Resetting the Dial on Diabetes Management in Long-Term Care Homes, presented by Doctors Lisa McCarthy and Iliana Lega. I hope you had a wonderful Family Day weekend. I recognize that this is not our usual time. We usually have the seminar on Mondays, but given yesterday's holiday, we appreciate your flexibility for joining us today. So before I introduce you to the speakers, I just want to go over some housekeeping notes. So first of all, we appreciate that you all know this by now, but just so we're on the same page, we appreciate our audience muting themselves unless you have a question, and there will be an opportunity for questions at the end of the session. We'll be inviting questions both through the raised hand function as well as the chat box. If you have questions during the presentation, please just put them in the chat box, and then we'll try our best to address them at the end. Please note today's session is being recorded, and we will make the recording available on the network's website along with our other seminar series. So now I'd like to introduce you to our two speakers. To start off, Dr. Lisa McCarthy is an associate professor with the University of Toronto and a Learning Health System Fellow with the Institute for Better Health at Trillium Health Partners. Guided by her clinical experience as a pharmacist, her research program studies the people, processes, and resources needed to co-design integrated care models with those they are intended to serve. She is the co-director of deprescribing.org, which creates evidence-based tools, resources, and approaches to support medication decision-making. She holds leadership roles with many organizations supporting optimal medication use. Dr. Iliana Lega is an endocrinologist at Women's College Hospital, and I have the pleasure of working with her there. She's also an associate professor at the University of Toronto and a clinician scientist at our Research and Innovation Institute at Women's College. She's also an adjunct scientist at ICES, and her research program focuses on diabetes management in complex populations, with a focus on older adults in long-term care. She's actually currently leading the update for the Diabetes Canada Clinical Practice Guidelines chapter on diabetes in older adults, and she previously led the Hypoglycemia chapter update in 2023. So without further ado, I'm going to pass it on to our speakers. Please go ahead.
Excellent. Just checking that we can see the right slides and we can see you can hear me. Excellent.
Yeah,
so welcome.
good.
Thanks so much. Welcome to everyone, and thanks to the network for hosting us today. So I'm Lisa McCarthy, and on behalf of myself and Iliana Lega, we're really excited to be here on behalf of the DIAL study team to share our work that aims to optimize diabetes management in long-term care homes. There we go. In terms of housekeeping, here are our disclosures. And as we know, the world works in teams, and DIAL is definitely a team. So in addition to Iliana and myself, we lead DIAL with Wade Thompson, who is a pharmacist and faculty member at the University of British Columbia and my co-director at deprescribing.org. We'd also like to acknowledge that CIHR, Trillium Health Partners, and the Ontario Centres for Learning, Research and Innovation in Long-Term Care at Briere Health contributed to the financial support of the work that we'll be sharing with you today. Every good session has objectives, so these ones are ours. Briefly, we'll tell you about the evidence to care gap that we're working on and share some of what we found in our quantitative looks at care patterns and through our qualitative work with care teams, residents, and families, and how we're hoping to build that to an intervention. So I've mentioned the DIAL study a few times, and you might be wondering, what is that? Well, DIAL is a research program that's using a multi-method approach to try and help reset the dial on diabetes management in long-term care. The problem that we're trying to address is one of overtreatment. And back in 2021, when we conceptualized this work, it was estimated about 25% of residents in Canada's long-term care homes lived with diabetes. Concerningly, Iliana had led some work that showed that more than 50% of residents were treated to intensive glycemic targets, so an A1C of less than 7%. And now, given that most residents live with moderate to severe frailty and usually have limited life expectancy, this is counter to global clinical guideline recommendations. So overtreatment with the unnecessary or even harmful use of medications was a key factor. But from our relationships, we also knew that overtesting and potentially restrictive diets were impacting residents' qualities of life. So our aim was to de-intensify diabetes management by reducing unneeded testing, liberalizing diets, and optimizing medication use through deprescribing. And this offered many potential benefits: a lowered risk for hypoglycemia and its consequences, reduced medication testing burden, on residents, streamlined workflow for caring staff, as well as potentially reduced waste to help the planet. We're a mixed group today, so I'll say a little bit more about long-term care homes to try and help situate our work. So in Canada, we have a ratio of about 29 long-term care beds per 1,000 people aged 65 over in Canada, and Ontario is very close to that. So in Canada, we have about 2,100 homes in total that are owned through a variety of public and private models. But in Canada, who lives in long-term care varies greatly by region. Now, everyone in Canada, all of the long-term care homes provide care for people who need access to 24-hour nursing care, personal care, or other support services. And the majority of costs are covered by our government. Physician services are typically provided by family medicine trained practitioners, although we're seeing more nurse practitioners in this space. Family medicine is typically on site weekly, and they begin their relationships usually with residents and families at the time of admission. We know that homes are struggling to maintain their staff and fill their nursing, their personal support worker, and dietary aid shifts. Now, in Ontario, we have about 627 long-term care homes, which house about 78,000 residents. Homes operate again under a mix of ownership models. Nearly 60% in our province are private for-profit organizations. The mean age of residents is about 84, though some regions have a higher median than that. 1 in 2 residents are admitted from the hospital, and all live with complex medical needs. Nearly 90% require support for activities of daily living, and most live 75% with moderate to severe cognitive impairment. Now, with demographic shifts in our population, the demand for admission has never been stronger. Ontario has more than 48,000 people on the wait list for admission, and the median wait time for admission is somewhere between 150 and 300 days across the province, but it's longer in Toronto with wait lists about 2.5 to 4 years, and in Peel that number is even higher. So what should you take from this? Well, our LTC system is under pressure across the country and in Ontario and in Peel. The demand for admission has never been stronger. Resident complexity is increasing, and we face large staffing continuity challenges. It's within this context that we are conducting our work. So when we talk about dial, we're using a holistic approach to try and reset that dial. We start from the position of our residents and families in terms of improving quality of life. Ultimately, though, we're in pursuit of that quintuple aim: resident, family, and provider experiences, as well as population health, resource stewardship, and equitable care. So how are we doing this? Well, I've mentioned our multi-method approach. We're exploring what we can learn from available data sources, and pairing that with qualitative work to explore experiences of care teams, residents, and their carers. And with this in hand, we will use this to co-design and use implementation science approaches to build and do early testing of a multi-component intervention. Now, our work would not be possible without our partners and the evidence-based tools and resources that we have and are creating. I'm going to turn it over to Iliana now to share more about what we found from our quantitative work with ICES data.
Great, thanks, Lisa. So I'm going to build on what Lisa already told you about sort of the context of diabetes in long-term care, and I'm going to walk you through the first few studies that we've led with our CIHR grant, which really have focused on better understanding current care patterns in diabetes in long-term care. So Lisa already mentioned that LTC residents are really a population that lives with frailty, a lot of medical conditions. And just to sort of put a number to it, these are also very elderly and old individuals. So the average age in LTC is 83, and more than 55% are 85 years of age or older. So really people at the end of life. So not only that, the level of comorbidity is very high. This graph is unfortunately a bit old now because it ends in 2015, but it really just, it's there to kind of just show you graphically the level of comorbidities. So hypertension, extremely common, over 80%. Cardiovascular disease going along with that is also quite common, osteoarthritis, but dementia rates are very, very high in long-term care. And most recent numbers are that it's up to 75% have dementia or cognitive impairment. And this really needs to be considered when we think about how we're going to manage other chronic conditions as well, because the individual's quality of life and other medical conditions really need to factor in a way that doesn't really come to play as much in younger adults with diabetes, where the focus of their diabetes care is really their diabetes. Next slide. So because of this, guidelines, there are specific guidelines for how to treat and manage older adults, because the focus is not just about their diabetes and other things that affect the individual. There needs to be a framework and how to really properly manage their diabetes in the context of their other conditions. This is one example of a framework that's used and adopted from the American Diabetes Association, and they call it the 4Ms framework. But again, it just allows you to sort of logically and systematically go through the things that you need to think about when you have an older adult clinically in front of you with diabetes. And so these are things, so the first M is what matters most. So this is really the context of the individual. What are the goals and expectations of their care? What is their day-to-day life like? And this is very important for LTC patients where there is a high degree of impairment with regards to functioning and cognition as well. Medications takes on a very, I wouldn't say it takes on a different role, but you have to think about medications in a different context for older adults, really thinking about what are the risks, potential risks of these medications. And for older diabetes medications, really the risk of hypoglycemia is a really key thing that you need to consider when you're treating a patient with the sulfonylurea or insulin. Because not only are older adults more likely to have hypoglycemia, if they have a hypoglycemia, they're much more susceptible to the ill effects of that hypoglycemia, which can actually be as devastating as death, but really involve falls, fractures, heart attacks, and poor brain supply, blood supply to the brain. So thinking carefully, but beyond sort of hypoglycemia, there's also other side effects and risk factors which come into play now with the newer medications we have. And so again, very carefully considering what is sort of the whole range of benefit to risk of this medication. Mentation, we've already said this, there's a very, very high burden of cognitive impairment and severe cognitive impairment in these individuals. So that needs to be taken into account in deciding how to treat. And lastly, mobility too, and other measures of frailty and well-being. Next slide. So because of that, the approach to diabetes management is going to be quite different than a younger adult. And some of these things we already talked about, but just again, the goals of care are different. The goals of care are not so much disease prevention in terms of preventing complications from diabetes, mostly because these individuals, unfortunately, will not live long enough to see that prevention pay out, because the number of years you need to treat someone to an intensive glycemic target to prevent complications is on average 8 years from our earlier studies. So the goals really shift then to comfort, safety, quality of life. I already mentioned hypoglycemia, but thinking about avoiding hypoglycemia should be a real tenet of how you choose a treatment in this group. Simplifying treatments, especially for those individuals who are more independent, not living in long-term care, but even in long-term care where there's such a burden on caregivers and providers and such a difficulty of staffing long-term care, having a treatment plan that's simple is important, both for the well-being of the care staff, but also to prevent issues and errors. Individualizing treatment targets, and then again, reducing the unnecessary need of medications. And again, this table is just to summarize the different goals of care. And so in younger adults, we really think carefully about prevention, but we really also think about A1C targets. And I bring this up because it's going to come up with some of the studies we've done where we're very keen on keeping the A1C less than 7% to prevent complications related to diabetes. As you get older, and certainly as you get older with frailty and comorbidities, that the A1C target relaxes. And this is in most guidelines nationally, certainly and internationally as well, where you have more of a range of an acceptable A1C that goes up to 8.5%. And very importantly, because this will come up in our study, in LTC, the recommendation is actually to avoid relying on A1C, which means you don't need to be doing as many A1Cs, because the goal is not to get that A1C in target, but the goal is really to prevent symptoms of overtreatment or undertreatment, hypo or hyperglycemia. So that brings us to our first study that we did, and Lisa already mentioned this a little bit. We initially wanted to just see what is the prevalence of diabetes in Ontario long-term care homes, because believe it or not, there was not up-to-date information on this in 2023 where we published a study, and the most recent study had shown a prevalence of 25% of diabetes prevalence. And we knew, given recent changes in the epidemiology of diabetes and reports from the US, this wasn't quite accurate. So we decided to look at not only the prevalence of diabetes in Ontario using our validated data sources, but also regional variability. And again, this was straightforward as far as the study design. One important aspect, though, was that because we're looking at long-term care, we use the resident assessment tool instrument, next slide, which is a really unique data set at ICS for those of you who are familiar with it. We often with the population administrative data, our Achilles heel is that we don't have a lot of clinical variables. You have all the diagnostic codes, you have all the testing, you have all the hospitalization, but you don't have those sort of more clinical variables on a population level. The resident assessment tool is a really unique tool in the databases because it's a standardized clinical assessment tool that is collected and mandated by law to be collected on residents in long-term care. So it provides us with some unique variables, such as cognitive, a validated cognitive performance scale beyond just a diagnosis of yes or no to this patient have diabetes, as well as markers of functional status. So again, validated ways of assessing activities of daily living, which include things like mobility, toileting, incontinence, falls, but it gives you just a better feeling of who your patient population is. And certainly some of these variables you can use for outcomes as well. So I just wanted to highlight that there, because when I first started working with these databases, I was really excited by the ability to have more clinical variables. But in terms of our study with the prevalence, so what we found was consistent with what had been reported in the US studies, that there's a much higher prevalence of diabetes in long-term cares than was previously reported at 25%. So it's over 35%. That's the reported prevalence. And over the 5 years of our study, which was 2017 to 2021, there wasn't a lot of variation. That prevalence really stayed pretty stable. And there was a difference between men and women, which is not surprising, with more diabetes in men, higher prevalence in men than women. What's interesting here on the map is just our regional variation, and I think it's interesting for this audience, is that certainly we did find the highest prevalence, over 40% diabetes prevalence in the Central West Lynn, which would capture part of Peel as well as Brampton, and also one of the highest prevalences in the Mississauga Halton Lynn as well. Whereas with other, in the Toronto core Lynn as well, the Central Lynn was a high prevalence, and with prevalence up to 40% there. Next slide. We looked also at characteristics of those who had diabetes versus those who didn't. These variables aren't as surprising, but certainly those individuals with diabetes tended to be younger. They'd had a shorter stay of LTC, length of stay in LTC. They had lower rates of severe impairment versus less severe impairment. More likely to be overweight, which again is a neat variable we can get from RAI, not usually available from population level data. And again, the higher prevalence among men, which goes along with sort of standard epidemiology of diabetes. Next slide. So after that, we wanted to look at what is the frequency of testing in diabetes in long-term care. So as I mentioned, based on the guidelines, the testing should be less because the goals of treatment should not be focused on numbers such as A1C. So we looked at this. So we looked at a few variables. We wanted to look at the frequency of testing for glucose-related values, so A1C and a serum glucose. But we also looked at other testing variables that would be done for for prevention of complications in a diabetes population. So we looked at lipids. We looked at screening for urine ACR for a marker of early kidney damage, as well as glucose monitoring. Next slide. We can skip that because I think I went over that in quite some detail, how A1C is not recommended in this population. So what we found was that there is a lot of testing going on, which was not surprising, but a little bit disappointing. So almost 50% of a cohort of residents with diabetes in long-term care had more than 3 A1Cs done a year. So that again it goes against guideline recommendations. About 20% didn't have any A1Cs done, and then about a quarter of residents had between 1 and 2 tests. So a higher proportion of A1C testing than one would think would be necessary given what the goals of care should be. Less glucose testing. Again, a random glucose on a blood test is really not a useful test. The A1C, yes, you could argue, but by the time that random glucose is seen and processed by the lab, that glucose is now 24 hours later. So again, a likely unnecessary test. About 20% of individuals had prevalence of that, and then about a quarter had 1 to 2 of these glucose tests a year. What was interesting, I think you can click next slide, Lisa. We also looked at monitoring, and this is very interesting right now in the world of CGMs. Really, many people recommending using them more and more in the older adult population. So when it came to just good old-fashioned capillary glucose testing, about half didn't have any tests in a year, and this would be considered very reasonable and appropriate because most individuals would not need capillary glucose testing on any level of frequency. But about a quarter did have more than 3 tests a day. And oftentimes, if standard to do capillary glucose testing would be around 4 to 5 a day if you're doing frequent testing with every meal, as would be the case for individuals who may have insulin-dependent diabetes. So we found that about a quarter of individuals had the type of more frequent testing. When it came to the continuous glucose monitors, we know there's not a big uptake yet in nursing care. Part of it has to do with how these monitors are reimbursed, that you need to be on insulin in order for it to be covered by the government. But about 10% had evidence of ongoing use of these CGMs based on having more than 2 supplied in a month. About 15% or so had 1 sensor per month, and most individuals, 82%, didn't have any sensors dispensed to them. Next slide. The other thing we looked at were predictors of monitoring. This is specific for A1C. We wanted to see if we could determine what factors and what sort of either individual factors or demographic factors are really related to increased testing. When you look at these numbers, they're all pretty similar. They're all in the range of 2 to 3, which means that there weren't really any there were statistically significant reasons why someone has slightly more testing than not, but nothing really that was driving the testing. So you would think maybe age would be one, but when you look at age, yes, individuals who are older had slightly less testing, 2.89 tests per year compared to 3.3 tests in those who were younger. Being on diabetes medication impacted A1C testing, but if you see, those individuals who are on no diabetes medication still had 2 tests per year, which again, in an outpatient younger adult setting would be reasonable, but in this case, it is hard to clinically explain. Similarly, A1C did have some impact on testing. So those individuals who had a higher A1C were more likely to have testing. And that, again, clinically makes sense. But the degree of testing is still very, very high for those who are in the more recommended A1C values of 7.1 to 8.5%. And similarly for cognitive impairment, those who are most cognitively impaired had less testing, but still 2.8 tests per year. Next slide. So our third study, really, we wanted, after we finished looking at the testing, we wanted to understand what is the pattern of use of medications in older adults in long-term care. And the reason this is a very interesting question right now is because over the last 10 years or so, there has been introduction, of course, to our formulary of SGLT2s and GLP-1s. And those currently, there are not clear recommendations on how to incorporate these drugs into practice for LTC, which is, again, a frail, old population. And we are curious to see how their introduction may have influenced their use and the use of other medications. And so we looked at this over the last 15 years, starting from 2010, which would have preceded these drugs coming on the formulary until recently. Next slide. And again, as a clinical reminder, currently metformin is still the recommended first-line medication for diabetes, whether or not you start it along with another medication for more of the cardiovascular protection that can be, you can get benefit from SGLT2s, GLP-1 is a different question, but certainly metformin, just to remind everyone, in general, is the recommended first-line medication. And there's really no clear guidelines for older adults and how to incorporate these newer medications. Next slide. So these are our findings. It's a bit of a busy graph, but we were very shocked when we saw these. I'll walk you through it as I think is relevant. So first of all, the top line is metformin. That's the dark blue line. And you can see over the study period, metformin use declined quite steadily and consistently over the 15-year period. You'll see in some subgroups, which I'll show you later, that metformin actually has surpassed some other medications, but we'll get to that. Now we're just looking at all residents in general. Now, the blue line here, the light green line here at the bottom that goes up around 2014 and then starts dipping down are DPP-4s. So DPP-4s, of course, are an oral medication, the sister or brother medication of GLP-1s, if you will. And so they also came, sorry, I should have mentioned them before, but they also came on the market around this time. And they certainly rose, but over the recent years, their use has really been declining. And this is something that struck us because DPP-4s, yes, they're a relatively neutral medication when it comes to the benefit you're going to get either on A1C and certainly cardiovascular risk, but they're very well tolerated. And so if the goals are really to prevent symptomatic hyperglycemia, they don't cause hypoglycemia, and they certainly do lower, they are a reasonable glucose lowering. So we were surprised to see that they lowered. Now, the real interesting point here is the yellow line, which is SGLT2s. So you see them starting to rise around 2016 because that's close to when they came on the market, and they've steadily increased. And similarly, GLP-1s is a purple line, and they have gone up slowly since 2020 or 2019, not nearly as high of a rate of uptake as SGLT2s, which makes sense in terms of the side effect profile and also the fact that it's an injectable medication, I suspect, but certainly rising as well. The other two drugs here are insulin and sulfonylurea, and that's kind of the good news story of our study here. But the gray line is sulfonylureas, which are an oral agent that cause high risk of hypoglycemia. And we can see since 2010 up to our study period, they really declined quite dramatically, which is a very good news story because these are medications that are have a very high risk of hypoglycemia or are dangerous, I would say, for older adults. And similarly, insulin, which is a red line, red little dots, it's a slow decline. Definitely the trend is downwards, but we recognize that, insulin is used in many situations where you can't use an oral medication. So seeing a complete decline of that line would not have been appropriate. I already alluded to this because I find it so interesting, but when we looked at these same trends by age, what to me is the most shocking is the first panel here, 65 to 74, where you see the blue metformin line dipping underneath the yellow line that's going up, which is SGLT2s. And this is suggesting that there is more usage of metformin than SGLT2s in the younger older adults in nursing home. We did not see that in the other older age groups, which is reassuring. And in fact, metformin's decline was not as dramatic in the older subgroups. Next slide. Finally, we are in the process right now of finalizing our paper on de-intensification. So de-intensification has become an important aspect of managing individuals with diabetes. It relates both to medications and to testing and diet and other behaviors that are recommended. And it really has to do with the fact that less is more, if you will. And so when it comes to medications, because of either the risks of the medications or some of the side effects, it's really best to simplify and reduce the medication because they're either not needed or they can be substituted or changed. Similarly with testing, as I mentioned, A1C testing is not recommended in this group, so decreasing testing is a process of de-intensification. And it's a recognized approach to treating diabetes. This is a pretty busy schema from the American Diabetes Association, but I've circled there that step 3, after you've really assessed your individual in front of you and their other comorbidities, thinking about de-intensifying or simplifying is a really important aspect of their care. So with that in mind, we wanted to see that among nursing home residents with diabetes who are newly admitted to a long-term care facility, thinking that that might be a time when there might be a reevaluation of medications, what is the rate of discontinuation of medications or a decrease in doses of medication, which we term de-intensification. Because of our databases, we couldn't look at things exactly how we wanted to. So this exact definition was a cessation of a GLP-1 if the individual was on it at baseline, or cessation of insulin because we cannot look at dose changes, or a reduction in or discontinuation of any oral diabetes medication. Next slide. So in this study, we had our cohort was 11,000 newly admitted residents with diabetes who had to be at least on one medication at baseline in order to be able to be eligible for a de-intensification event. And we actually found that quite a few residents, not surprisingly, were on more than 3 diabetes medication, 30% of them. There were 38% on insulin, and the vast majority were on metformin. And what we found, again, with this study, again, I'm editorializing here, but we felt we felt there were more de-intensification events that we thought we would find, which is a good thing. 42% of individuals underwent a diabetes de-intensification, and some of them more than one event, given that they were on multiple medications. Those who were most likely to have a de-intensification event were those who were on insulin at baseline, and this might reflect short-acting sliding scale insulin that was added in the acute care setting that led to them coming to nursing homes. Similarly, sulfonylureas were among the drug most likely to lead to de-intensification, as well as GLP-1s, and SGLT2s very much more at the bottoms. We also looked at other resident demographic related factors that may be associated with de-intensification. Again, being older was more likely to lead to de-intensification. Having a low A1C at baseline, which we were very happy to see, was also associated with more de-intensification because that's the way it should be. Similarly, having more functional instability was also associated. Cognitive status didn't impact de-intensification rates. And I think that's like the most salient from this. So at the end of the admin part of our grant, we really still have obviously unanswered questions, but it's really helped us formulate, and this is where Lisa's going to take over, what are the next steps and how we should incorporate these findings into the next step, which is really to find ways to optimize diabetes care. So what are the optimal testing strategies for individuals in long-term care? Because certainly right now we've identified that there is likely too much testing going on. How should these newer drugs be used in practice? Because when we give talks and when we engage providers in these settings, there's a lot of confusion and about how to use, when to use these drugs, and they're actually getting pressures or information from different settings that's really encouraging them to use them a lot in this case. So what evidence is there and how should they be used? And finally, this idea of diabetes optimization versus de-intensification. So we found the great drop in metformin use. Is this a good thing? Is this a bad thing? It's certainly not guideline driven, but what, again, kind of along with the second point there is how should other drugs that have come into play really be, how we should use this information to guide our treatment practices. So with that, I think I'm turning it back over to Lisa now.
Thanks, Iliana. I appreciate walking us through the quantitative part. My task now is to take you on a whirlwind tour of some of the qualitative data that we've collected. So we'll start with talking to you about the experiences of care teams, and then I'll share you some early findings from our residents and family caregivers. Okay, so in the first study that we did, we explored how the care team works together to manage care for residents with diabetes. And we also wanted to identify opportunities for care process enhancements to inform our intervention. So supported by an accelerator grant from Trillium Health Partners, we conducted interviews with care team members at one not-for-profit home in the Greater Toronto area. Now, as you can see, we conducted 11 interviews and we had good representation across the care team. What did we learn? Well, there's a lot here and it's quickly summarized on this slide. So first, team members reported that collaboration was central to diabetes care, including managing diets, testing, and medications. They felt they did this collaboration reasonably well, but they recognized that more resident and family involvement is needed. Within diabetes management practices, they acknowledged variability in their approaches depending on the practitioners involved, but also the clinical circumstances. So for example, consistency was higher when they were managing acute hypoglycemia because they was protocol driven, whereas instances of hyperglycemia, on the other hand, were managed much more case by case. And lastly, acknowledgement of overtreatment or the need to de-intensify vary really across the care team, with some members identifying testing frequency and medication use as a concern, while others did not. Now, I'm somebody who loves qualitative data, so I wanted to share these quotations with you just to showcase the theme related to varying acknowledgement of overtreatment across the care team. So some team members identified testing frequency and medication use as a concern, as you can see on the first quotation, while others did not, particularly when it came to their own behavior. And you can see that contrast here on this slide. To support future interventions, there were several recommendations. So team members reported that they generally did try to collaborate to provide care, but we have work to do in terms of their recognition of, knowledge about, and comfort in managing many areas related to de-intensification. To support this, they wanted more education, which they always say, and increased access to specialists who know diabetes, particularly related to hyperglycemia. We were told, again, that hypoglycemia management was pretty consistent because it was protocol driven. Hyperglycemia was a big soup of mix of practices. Teams also discussed ways to involve residents, when able, and family carers in the care processes, particularly related to diets. So one example was teaching families to inform care team members when residents are consuming treats. We heard a lot about the challenges of Timbits in terms of managing glycemic control. In our second study, what we did is we interviewed residents and caregivers to explore, family caregivers, to explore their perspectives about diabetes management, including de-intensification, and to gather their views about potential process improvements for diabetes care. So to be eligible to participate, residents had to have diabetes and be able to consent and participate in interviews, which, given that the environment that we're working with, didn't mean that everyone could participate. Potentially eligible residents then were identified by health professionals at 3 of our partner long-term care homes, and we used a validated tool to assess their capacity for informed consent. Caregivers, on the other hand, had to be at least 18 years old and self-identify as a family member or a friend of a resident with diabetes. And we used many ways to recruit those caregivers through our partner LTC homes and through advertisements circulated by groups like the Family Councils of Ontario and the Ontario Long-Term Care Association. Overall, we interviewed 14 family caregivers and 13 residents with diabetes, and you can see their characteristics here on the slide. In terms of findings, these two quotations actually capture common feelings that we heard from residents and carers about their current care experience. In the first quote, the resident is describing a transition in their autonomy. For years, they had self-managed their diet, testing, and medications, and now they were surrendering all of that to someone else. In terms of general experiences, many residents were happy with the care team and felt they would trust their recommendations. Some, though, had experienced situations where a personal support worker or a nurse seemed uncertain when they were using, a glucometer or giving medications, and this led them to question whether they could trust the quality of care they were receiving. Now, in the second quote, the carer expresses concerns about whether the amount of time being spent with residents is sufficient to truly understand their needs, especially when residents are not able to communicate for themselves. Carers were very aware of their staffing realities, and they reported a continuous influx of new staff and high resident to staff ratios. Importantly, they weren't confident that anyone really knew their loved one. They also described many communication challenges between themselves and the care team, and as well observed between care team members. And this led them to question the quality of diabetes appropriate care being provided. In the interviews, we also asked them about de-intensification. And for residents who were happy with their current care, most said they would agree with the care team recommendations. It was a tougher sell for those like the quotation featured, where the resident emphasized the importance of frequent testing as it helped them to feel safer and more in control by distinguishing between symptoms and actual blood sugar levels. For carers, some knew what de-intensification was from the care team. Others, if unfamiliar, were generally open to de-intensification once it was explained, but they recognize the goals of care and needs change over time. So definitely not going to be a one-size-fits-all kind of approach. In terms of implications for our path forward, we had many recommendations related to residents and carers wanting to feel involved and informed. They wanted personalized and high-quality care. As I said, one size will definitely not fit all. Some residents want to be able to actively measure their blood sugar. They also value independence and control regarding their diet. Crafting educational messages that resonate with residents and families and delivering them creatively, and I saw Krista Lamb here and she knows our challenge, will be important for building trust and confidence about de-intensification. In terms of next steps, what we're doing now is we're working to complete interpretation of our findings through the theoretical domains framework and mapping our findings to intervention options. And all of this is to guide our next phase where we want to co-develop an intervention grounded in resident dignity, caregiver involvement, and resource optimization. As we close our formal part here, I want to highlight the other ingredients that are really needed for success. In particular, having evidence-based tools designed with users and having partnerships. So we're starting with a good, though not complete, foundation of evidence-based tools. First up, forgive the plug, we have deprescribing.org's clinical practice guideline to support deprescribing of antihyperglycemics. We've convened our international panel to update them, and through Iliana's leadership, I've been able to be involved with the Diabetes Canada Older Adults chapter as well, and we're looking on how we can synergize efforts between all of our groups. We also have a suite of tools that have been co-designed with residents and families to support shared decision-making about medicines, and tools developed with care teams to help personal support workers and nursing teams learn who should be referred for medication assessments. All of these are freely available on our deprescribing.org website, and use of these tools may actually be part of the intervention that we're hoping to develop. As part of supporting system change, we've also been actively using integrated knowledge translation approaches where we partner with the long-term care community and share information as we go. Sorry about that, rather than just at the end. The examples on the slide are some of the ways we've done this. So we've published short clinical primers, we've hosted professional development and knowledge exchange sessions with clinicians, and we've partnered with groups like the International Geriatrics Diabetes Society on statements they've worked on. We also worked with the Canadian Society of Long-Term Care Medicine to add diabetes focus statement to their Choosing Wisely Canada recommendations. And Iliana mentioned her leadership of the Diabetes Canada Older Adults chapter. So if there's anyone here today who's interested in partnering this space, we're always welcoming of new friends and new acquaintances because we're all stronger together. So lastly, we want to acknowledge the many partners working together on DIAL. And these organizations represent the long-term care sector, right? Homes, carers, pharmacy service providers, and leading diabetes organizations like Diabetes Canada and the Novo Nordisk Network for Healthy Populations. Importantly, to keep building momentum, we are continuously working to sustain these relationships, and we welcome new ones. System change is much larger than any one group. Finally, in addition to these partners, we want to thank our funders and our strong team of investigators, collaborators, trainees, and staff who've been involved with all of our efforts. So please do reach out, certainly if you're involved in or interested in getting involved in any of our work. Resetting the dial is going to take all of us, and thanks for joining us on this opportunity today.
Wonderful. Oh my gosh, I am so impressed with how much work you've done over the last couple of years. I'm blown away. Really amazing. And a lot of the questions that were coming up in my head, um, you're already answering, with your next phases of research. So I just love how you're triangulating data and methods from, observational epidemiologic database research with qualitative research and then implementation science and co-design. Really, really well done. Congratulations, and thank you so much for sharing your work to date with us. So I'm going to open it up to see if anybody has any questions. If anyone has a question, maybe they can just raise their hand or pose it in the chat. Okay, so while people are thinking of their questions, I had a question that I'm sure you get all the time. Beju, I'll get to you in a moment. I'll just give my question and then, yeah. So obviously, really interesting work, how we're seeing a decline in insulin use and a decline in sulfonylureas amongst our long-term care residents. And of course, we know that these drugs, have these adverse effects of hypoglycemia. So that's a compelling reason why we shouldn't use them if we don't need to. But, with the increase in SGLT2s and to the lesser extent, GLP-1 receptor agonists, there's some sort of mixed views perhaps about the safety of these drugs. They're not known to cause hypoglycemia, but they have other risks that may be more common in the elderly. So do you have some data that you could elaborate on, maybe specific adverse effects that we need to be aware of these newer medications in the elderly?
Yeah, Iliana, I'll let you. Oh, I was going to say you can take that, but it is the hottest topic when we talk to clinicians is this question. Yeah. Sorry, Ellie, go ahead.
Yeah. No, it definitely is the hottest topic, and it's something that we struggle a little bit with because there isn't, and now we're reviewing it all, of course, for the guidelines. There really is, for the LTC population, I would say there's no evidence of efficacy or benefit of the newer agents. For the LTC. So it's a very, very specific population. There is a small amount of evidence for older adults, even older adults with frailty, but not those who are institutionalized and have cognitive impairment. So GLP-1s, I think, are very problematic for this LTC group because of the side effect profile. And that side effect profile, of course, as you know, as a clinician who uses them, is the GI side effects and also the appetite suppression. So in LTC, that's a big problem in terms of ensuring patients have an appetite, that they're getting proper nutrition, and that a lot of them are losing weight as a part of their frailty, right? So when it comes to GLP-1s, I have a lot of concern with them being used. Luckily, they're not used as commonly as the SGLT2s. And certainly, but again, that's not based on data that they're more harmful, just because there is no data in this long-term care population. I think the SGLT2s are a more interesting question. So the International Geriatric Diabetes Society that Lisa mentioned, both her and I have been involved with, and in the US, they're quite more comfortable using SGLT2s. They do not feel that it's a problem. They find, clinically, in terms of controlling blood sugars, which it does a good job of. But again, that is not based on data. There is no data on SGLT2 use in this frail older adult population. We'll see with our newest reviews that we're doing for Diabetes Canada if we're going to find anything more evidence-based. The one thing I would say, there's a very interesting study, and Lisa, maybe you remember the details, that was published by Albert Huang. It's a risk prediction modeling. It's not, and so he through his modeling, he suggested that the quality of using an SGLT2 and GLP-1s in individuals who are within 4 years of end of life, which would include all LTC patients, just based on average length of stay, it doesn't actually, there is no benefit to using them.
Benefit.
They should not be used in that population. But that's a very unique study that I haven't really seen reproduced. But whenever we give talks on it, I tend to use that to sort of back up my clinical feeling and the lack of data that, that's the one kind of evidence we have against using these drugs, again, specifically in an LTC population.
Yeah, so there's those pieces. And Iliana, you remembered it right from pulling from your memory about Albert with what the findings were. But there's also now this new phenomena where GLP-1s are actually being require management, like being special handling in terms of when they're administered, but also like in terms of dealing with human waste for people that receive them, related to semaglutide and it being classified as a potential carcinogen by certain agencies. And so there's a whole side of this that's introducing a lot of administrative work for people using GLP-1s that we're also starting to hear a lot about in terms of concerns. And so lots of nuances. We could spend an entire talk just talking about those agents in the long-term care setting.
Yeah, and I would actually be really concerned about sarcopenia also.
Yeah.
For sure. Yeah, we talk about that.
GLP-1 receptor agonist,
Yeah,
right?
yeah.
And
Along with that,
especially
but no, you're absolutely right. Yeah, for sure.
Yeah.
I mean, one thing when this question comes up a lot, when this question comes up, I always go back to what should be and are the goals of care. So the goals of care are to prevent symptomatic hyperglycemia. If the resident is not having symptomatic hyperglycemia, which granted can sometimes be hard to clinically assess for in a patient with cognitive impairment, you don't need to add more drugs. That's sort of the bottom line. So if you're not seeing a problem with hyperglycemia, then use what's best, what's most simple and not causing any adverse effects. That's sort of
no, absolutely. And I think I'm so glad that you talked about the intentionality of making sure that there's education of not just the individuals working with these patients, but also their families and the patients themselves, because a lot of times, I mean, there's this misconception that the diabetes is somehow making things worse for them or somehow needs to be optimized to optimize their day-to-day health, right?
Yeah.
Where we need to maybe clarify that the only time it's affecting them on a day-to-day level is if the sugars are very high.
And I think that's a problem. And part of it is that a lot of these providers are primary care providers in long-term care. And so they're getting info sessions in general about primary care. And so they're really extrapolating what they're hearing to the nursing home setting with very good intentions. Like it's not, but it's just not appropriate.
Well, and also families have been taught, like,
and same thing.
Residents, tight control. What's your A1C? What's your sugars for so long? So it's really a paradigm shift that's required. And it's a challenge to get people's head around.
Thank you. Thanks for indulging me, Beju.
Hi, thanks very much. Sorry, I'm eating lunch, so I'm going to leave my video off. But thanks for a great talk, and it was really interesting to hear all of the work. And full disclosure for everybody else, but I'm working also on a project with Iliana and Lisa in this space. So the question I was wondering about was, it triggered my thought when you put up the picture showing the different utilization rates of the different meds by age group, and I'm just wondering, like, the 65 to 74 in particular, like in long-term care, is that not a qualitatively different population than the older ages? Because if you're in long-term care and you're 65, presumably there's something else going on too, right? So I'm just wondering if that might be, how important is that? Like, do you have any sort of—
That's a really good question. We haven't, because that study, we wrote it up as a brief letter. We didn't look at characteristics by age just to sort of further understand what those trends are about, but that's a really good point. We did look at the use, look at those graphs depending on presence of cardiovascular disease. And in those groups too, we found SGLT2s higher. But that's a good point. Actually, we should probably look back and see, because I totally agree with you. Yeah, it's a different population, the younger. First of all, I know that there's sometimes individuals in long-term care who are younger, who are unhoused, for example, and have different reasons or have developmental delays, and that's why.
Yeah, that's what I was thinking about, like other neurocognitive dementia.
So obviously their life trajectory and life expectancy is likely different and their ability, but that's a good question. We haven't looked specifically at the characteristics of that younger cohort.
Okay, great, thanks.
Thank you so much. Any other questions from the audience in the last few minutes? So if there are no other questions, I mean, I have a ton of questions. Thank you so much. Please join me in thanking Doctors McCarthy and Lega for a wonderful presentation, and congratulations on all this work. And we're really looking forward to the next steps. Yeah, and I'd be looking forward to seeing how you, some of the outcomes, because you have all those data now, through you have that baseline analysis of long-term care, the state of things in long-term care facilities. So now you can go back after you've intervened and see whether you've made a change in at least in the Peel region. Thank you again for speaking today. Thank you for being available for questions. And thanks everyone for joining.